Okay, good afternoon. I'm Dr. Bancha from Thailand. Thank you for the introduction. India is my second home. I've been there many times a year. And also, I love to come to Malaysia. I come to MS meeting every year. Okay? So, I'm talking about the PCL Transseptal Remnant preservation. It's my great honor to be on the stage with Professor Stobo. I read your book since I was young. So I thought that you're older than this. Sorry. Yeah. So look so young. Thank you. I'm talking about the Transeptal PCL reconstruction. Why we do remnant preservation? Because the PCL is so big. So our autograft never bigger than the PCL. Okay, so I agree with Dr. Strobo. We also always preserve the PCL. Okay, and also this remnant preservation, you can increase the vascularity and also improve the healing of the PCL. Okay. So you see that this is the PCL. After you do reconstruction, you put the PCL in the remnant. So this vascularity is like side to side. So you have better chance of healing of the PCL. This is my proposed technique in the arthroscopy technique I published 2 years ago. The Transseptal remnant preservation. We call pulley and lot technique. So we break the table, drop the leg down like this. We have 4 portals, 2 in the front and 2 in the back. Okay, I show in details. Most of the time I use hamstring for the graft, but in some situation, there's multiple ligament injury. I use the hernias longus for PCL and also hamstring. So first we clean the intercruciate, and then we go to the back of the joint. Okay, make a post-medial. It's important you should not get close to the condyle because that will obstruct your view. So we make put your switching stick behind the PCL. Okay. So now I develop my technique, the new technique I will show you later. Then we make a Transeptal. Change your camera from the anterior to posterior. Okay. From this you can see very well. Then you break the septum. Clean the septum, soft tissue in the middle. So this line you make a common roof in the back of the joint. You can see everything. Okay, you can, and you preserve everything. I identify the PCL that always just above the publicus tendon. Okay, make your hole. I put my aiming device from the back. Okay, not through the notch, but from the back. And then we pass the suture from tibia. I put the lot in. This is act like pulley and lot technique. Then we drill the femoral tunnel. Okay, pass the green. The green suture is for femoral tunnel. The purple is for tibial tunnel. Then we pass this graft from tibia. So the lot act like the pulley, change the direction of the graft. So you know that this is the typical step to pass the graft. Okay, then you pass the graft from tibia to the joint and then to the femoral tunnel like this. Okay, so this is our first technique many years ago, and very important. We put the guide, okay, in to the tunnel and put the screw close to the joint. Okay, because you reduce the killer turn effect if you put the screw in the joint close to the joint, and you get a big size graft. So this is our technique, but now we found that, yeah, we have developed a new technique we call the Transeptal. Yeah, this is intercruciate approach. We approach from the space between ACL and PCL. Then we have 2 windows, left and right. So you don't have to go between the PCL and the medial femoral condyle. Okay. And then you pass this switching stick, you see, from medial to the septum, and then you see another window from intercruciate. And then we break the septum, clean the soft tissue. Again, we preserve everything. Identify the footprint. That's the popliteus muscle, you see? It's always just above the popliteus muscle. If you didn't see it, that means you're not deep enough. Okay, I met my tunnel in the center. In the center, vertical tunnel. Okay, not from the medial side, because you have the second kiloton if you come from medial side. Okay, pat the suture from the tibia. Okay, put the switching stick in, and then we come to the front. So we work separately, front and back. Now identify the footprint. You see, I didn't touch my PCL at all, because I work separately, front and back. Then drill the hole. Okay. But now we change the technique. We did pass the graft from the front. It's easier. Okay, we put the guide in. So we pass the graft this way from the front to the back. Okay, we pass to the tibia first, and then pass this graft into the femoral socket. Okay, so we preserve all the remnant. And very important, you put the screw. This screw should be big. I put it one size bigger, okay, and close to the joint. I found that if you put close to the joint, you don't have to make a long graft, and the screw have to be close to the aperture, okay. And we found that our result getting better after using this technique, okay. So Transeptal technique improve your exposure. And also, if you read the article from Dr. An, we found that after you break the septum, the vascular dropped back. So you have more space to work. Okay, comparing this one and this one, you see, you have more space to work and safe to your vessel. Okay. For the tibial screw, I put it one size bigger, and I put longest screw. Most of the time, 35 in the market, that is the longest. Okay, and close to the joint. You reduce the problem of the kiloton. If you put it close to the near cortex, sometimes you have the problem because your graft still move in the tunnel. Okay, so this will reduce the problem. And also my tibial tunnel, I put it in the center. The center bone quality is always good. Okay, and if you put it like this, you have another 6 kiloton, right? Come from the medial side. So I prefer to put my tunnel in the center. Center always good bone quality. Okay? And vertical, I put the angle is around 65. So this is the article from Dr. An from Korea. He have a quite good 60 patients, and side-to-side difference is about 2.8 millimeters. So another good thing is if you do PCL reconstruction combined with the posterolateral, I prefer to do the posterolateral arthroscopically, like popliteus reconstruction. Okay, this is PCL. After you finish the PCL, then you just switch your scope from the lateral side to medial side. Then you can do the popliteus from the Transeptal technique. You don't have to make a big incision. Okay, you just take another 10 minutes to do the popliteus. Okay, you pass this graft arthroscopically. Okay, pass the popliteus into the tibia, and then pass to the lateral gutter, like that. Okay, so this is another benefit of the Transeptal. You will have good exposure in the back of the joint. Okay, so and then fix the screw. Okay, this is a popliteus reconstruction together with the PCL reconstruction. Okay, you have the small scar and also good result. So in conclusion, the remnant preservation, I think that improve the healing. Also, you increase the size of the graft. Okay, you have the side-to-side vascularity. And in the cruciate approach, Transeptal, you can approach from the front. You can see everything in the back. You improve your visualization. You can see everything. When you can see everything, you can make a good job. And also, it's safe to the posterior structure. And I prefer to do the tibial tunnel in central vertical tunnel. That will reduce the kiloton, and also you have better bone quality. Aperture fixation, like this, your graft will be big size. You don't need the long graft. You can get the small, big size but short graft. Okay, and you have less problem of killer turn and also no motion in the tunnel if you put the screw close to the joint. You see that good exposure is important. You look at this is not polite, right? But if you look again, okay, this is the importance of the exposure. If you have good exposure, you have no problem. Okay, thank you. We will have APCAS meeting next year in Thailand, in Pattaya. Please save the date. This is 9 to 11, Pattaya. Okay, please support us. Thank you very much.